screen?
Yes, we can see very well.
Yes. Yeah, I want to thank most of all to my friend Giuseppe Lancino who gave me this spot in this very important session. I already listen a lot of huge, very nice professors talking about the subjects, and for me it's an honor to be here today. And I just want to show you something a little about history, because we have today very young neurosurgeons who are interested in develop something in learning, in improved neurosurgery, and that's what we are listening today from all our previous lecturers. I'm going to talk about the minimal invasive posterolateral transcavernous transtentorial transtrigeminal approach. Very complex name, but I will try to show you that it's not so complex. I think the cavernous sinus changed these last 5 years, and now we can use it a lot in order to operate different things. This is my conflict of interest. I'm very grateful first with my mentor, Professor Evandro de Oliveira. I made a fellowship with him in 1998. And I learned there for my two colleagues, Elder Tedeschi and Wen Kung Su, that the neuroanatomy and microsurgery are the most important things that we need to know. And it's very important for the surgery that we will try to talk in 10 minutes today, because if you see that picture, it was a dissection that Elder gave me in that time, Elder Tedeschi, and you can see everything there. You can see that between the posterior clinoid and the petrous apex, you have nothing more than tentorium. And then if you can take out the tentorium and control the venous bleeding from the cavernous sinus, you have a very good highway to the posterior fossa and to deal with any lesion in the middle fossa and the paraclinoid region too, the anterior clinoid process. And then it's very interesting because most of the neurosurgeons I see that try to go from the middle, anterior and posterior clinoid, for example, Hakuba, Dolens, or lateral, for example, Kawase. But few surgeons want to go through the cavernous sinus because everybody said to us that this was dangerous. Okay, if you see for example, the history in paraclinoid aneurysms, you can see from Canada, Charles Drake described the subdural craniodectomy. Hakuba from Japan described the extradural pure craniodectomy, and Dolens from Europe described the combined. Because different schools have different view of what is the cavernous sinus philosophy. But for me, the one that I pick up and I thought that was better was the Japanese one, because you use the extradural corridor. And the extradural corridor give you something that no other way give you, that you don't need a big craniotomy. You don't need the orbit, you don't need the zygoma in order to get the profound structures. And the first thing I did as a surgeon, I was very interested in paraclinoid aneurysms, and now I have operated almost 500 cases. I know that in the 21st century, the endovascular treatment is a very good option, but when you have visual compromise, for me, still the microsurgery is the best way. But it's complex surgery. You need to deal with the cavernous sinus, with the roof of the cavernous sinus. And then my interest was always, this is my work that I did in year 2000 when I entered to my society, and I studied this subject because it's very important. This is for the young guys, okay? The things never came from one day to another. You need to put effort. You need to put a study. You need to pick up your heroes. You need to put a face in what you want to do. Dolens, Hakuba. I had I was very lucky because I knew all of them. I was very, very lucky. Now they are not more with us. Professor Evandro as well leave us 4 years ago. And then the other thing is the teamwork. This is the operative notes of my first cases. In that time, if you see the name that I put Hakuba Dolens approach. Now it's accepted that Hakuba was the first one. But in that time, in 1999, everybody thought that Dolens described anterior craniodectomy, but Dolens described the combined, not the extradural. This is my family. They were so important for me that I put to my first dog, I put Dolen, the name of my first dog who passed away the last year. I love him too much. And I always try to follow this in my life. If you see the original draw of Akira Hakuba in the upper diagram, you see that all the anatomy was there. But if you compare what we have now with the microscope, we have much more details in our surgery. That's very important. The same thing with Dolan. William Caldwell, very brilliant neurosurgeon, who described the first one to describe the neurolysis or freed or the microsurgical freed of the lateral wall cavernous sinus nerves that we use today. And the other thing is the combination with less invasive approach. This is Edgar Natal and Everval Gadera Figueredo from Brazil and Mexico. They described the mini-pterional approach with Professor Spetzler and Peter Nakagi. And then if you combine this less invasive approach with more dissection of the cavernous sinus, you have the Platta. This picture I took with all of them, Evandro, Rocuya, and Professor Dolens. And then I made the same surgery for 15 years. I was a classic surgeon. Very nice to be classic surgeon, but I think I need to change something. And then we came with this concept to apply less invasive approach. This idea came from Rafael Martinez Perez, a Spanish neurosurgeon who works now in the United States, brilliant fellow that I have a few years ago, and he pushed me to try to publish all of this. And then if you see the concepts, this is not a fashion. We have only 2 references in the literature about mini pretemporal approach. This is the name of the approach that I'm showing you today. This approach have 10 years, but only 2 references. And mini pterional have 100 references. But we are putting the concept in the literature, and we have the papers. And the other thing is always you must be surrounded for young guys because they have the better ideas. And we have this. We published a video. This is Arnaud Bennett. He worked in California. He made the residency with Michael Lawton. And we published this video. And you can see the video for free in the internet. This is the QR code that you can copy. But I want to show you we have different levels. You can deal with paraclinoid. You can deal with clinodal meningiomas, or you can deal with posterior fossa lesions with this approach. I only have 3 minutes left. I just want to show you that nothing is new. This was described in 1982. Our difference now is better knowledge of the neuroanatomy, better instrumentation, better intraoperative imaging. The microscopes are much better, the icy green, and we have a lot of tools today, intraoperative monitoring, and a lot of things that improve our practice. Everything is about anatomy. The mini pretemporal approach is a modification of the mini pterional approach. Is anatomy based. For the young guys, when you do something, always think why I'm doing this, why I try to do less craniotomy, because it's not needed. In life, you never do things that you don't need to do. You try to be efficient in your life. You must be efficient as a neurosurgeon. This diagram is, of course, from Rafa, and he put this. The mini pretemporal that we are showing today is different from pterional. It's different from mini pterional. It's an evolution of the concept. And then the anatomy is very important, just to show you that the dissections are very important. This is for Maxi Nunez from Argentina. And the surgery, you can do the same. You must do the same. You must try to find this in your surgery, to see the Gruber ligament, to see the 6th nerve, the 3rd, the 4th, everything. You can see all of this now in microsurgery. And then, for example, this is we have 127 cases up to date. I made the last one on Thursday. This is a cranopharyngioma that I take out for my Platta approach. You can see all the anatomy. The posterior vein of the carotid artery, the 3rd nerve, the 4th nerve is we made a transposition, is mobilized. Put in the side of the 5th nerve, you can see the basilar, superior cerebellar, posterior cerebral artery, PCOM, anterior choroidal, superior hypophyseal artery, everything, all the anatomy, all preservation. That's all about. And you can combine with endoscopy. You need proper instrumentation. We use Japanese instrumentation. And our concepts are used in different countries. In Canada, for example, the new re-expansion of the skull base. This was a presentation of a very nice colleague, Radovanovich from Canada. And he showed that we can modify the techniques, and he based his lecture in our paper that we published. And I want to finish because I only have 1 minute, saying to you that you need to publish, you need to share your knowledge, you need to develop new instrumentation for new approach. For example, these ranges that we develop, the veins, always important, everybody knows it. You need to be fair with the neurosurgeons that we were before us, Dolens, Hakuba, Kawase, Caldwell, all of them. And you can deal with terrible cases with very good results. This patient, we take a sphenopetalocleidomastoid meningioma. Now we have more than 75 cases and different levels. I want to finish my lecture saying thank you to Dr. Evandro, who started with these concepts, the people from Taiwan who do this, and saying to you that 25 years ago, we started a fellowship in Chile. Now we have 60 neurosurgeons that they made a fellowship with us, and we started in April